So let's keep talking about our glaucoma stuff, right? All right. Any other questions I can answer before I get started here? Hmm? ENT will be the next one. Yeah, so with that up in section 2. Yes, ma'am.
Is it still divided like antibiotics are half of the exam and then
When I did it, yeah, it was roughly 50% section 1 and 2, sort of those principles and getting into the antibiotics themselves, and then about 25% of the other two, roughly speaking. So it was pretty close, I think. Yes, ma'am.
I had trouble like seeing the stepwise reassurance like to treat acne. What is like the right step?
Okay, so what do you think?
So
Hmm?
when I did it, I thought it was a topical of like the OTC.
Okay, right. So what's the easiest thing to start with? Yeah, over-the-counter benzoyl peroxide, right? And most patients have probably tried something similar to that, correct? Most of the time they tried something, right? So I got all this acne, and we go to the store, buy something, and the first thing I pick up off the shelf is probably going to be some kind of benzoyl peroxide containing compound, something similar to that, right? So okay, so that's kind of your first step. So then what can you do from there? Hmm? Right, so that could be another step, right? Remember, also with the benzoyl peroxide, there are stronger concentrations that you can get maybe that aren't over the counter, right? So those are other things to consider. But think about, what kind of reactions are they having to it? Are they getting a bunch of like, they're having a lot of irritation related to the medication? Are they having issues with in terms of administration? Because remember, benzoyl peroxide. We have to think about when adding other medications to it because it may inactivate some other things. Like we talked about retin A can be inactivated by the benzoyl peroxide. Okay, so then we talk about topical retinoids, right? So that could be something we could try next. And then what about after that? Good, topical antibiotics would be good. What if it was like really just diffuse and it's kind of all everywhere, right? It's all over the back and on the chest and the face. Right, then you also consider systemic what? Now, would you go systemic antibiotics or systemic retinoids first? I'd probably think more of the antibiotics, right? When you're looking at the risk versus benefits, what do you think has potentially more of the negative? Was it acyclovir?
No, it's the
Isotretinoin. Isotretinoin, it's a pretty nasty drug overall. It's very effective at what it does, but I mean, the skin just gets kind of fried from it until they kind of get used to it. You use a lot of emollients for that. The depression risk. You have to go through the eye pledge, which is another huge hassle, right? So using something like a systemic antibiotic may be reasonable for those patients there, and then if that's still not really kicking in, then maybe consider something like the systemic retinoid, right?
So on the PowerPoint that I was discussing the acne, it had the top or the systemic retinoid before the systemic antibiotic. So do we need to, in our minds, should we switch that?
It depends on the right. So a lot of it could be coming down to the patient specifics. Okay, so when you say systemic retinoid, again, we're talking about isotretinoin. Like, look at the patient factors here, right? Is it someone who maybe wants to get pregnant coming up soon? Like, maybe that's not a great drug for them, right? If it's someone who maybe not compliant with getting their pregnancy test done and doing all these things, that could lead you to thinking one thing or another, right? So again, the scenarios are going to be designed not to trick you into thinking, oh, it could be this, could be that. It's usually pretty clear cut. If you miss a contraindication, then you get the wrong answer. But if it's something where like, a pregnant patient comes up, which of these medications would be contraindicated? Like obviously isotretinoin would be contraindicated. What kind of antibiotics would be contraindicated? Tetracyclines aren't very good for those kind of patients there. So these are things you're kind of looking for, right? So again, very patient dependent. And again, if I was working in derm for 20 years, I might have a different opinion on the sort of thing there. But this is kind of what the stepwise approaches we sort of see here, right? Someone else have a question?
Benzoyl peroxide, does it only inactivate tretinoin or all the?
Yeah, so the other ones we talked about tend to be a little bit more stable, right? So we mentioned that in like what's the next one?
So it's just
Well, no, azelaic acid is more kind of similar to the benzoyl peroxide in terms of its activity. When you get into like adapalene, I think was one that was that specifically is not going to be inactivated there, right? So it's a little bit more stable. Again, these are great questions, but again, earlier is always better for these kind of things, right? And again, I'm not saying this like to chastise you by any means, but I'm just trying to say this close to the test, it's really tough to internalize a lot of this knowledge, right? So if you can think about these things beforehand and be like, oh, I'm just curious, even if you're not really confused on topic, just email me, right? I'll be sure to get back to you pretty quick, and then we can kind of clear up any kind of misconceptions, anything like that, okay? Because the time to ask questions is definitely not right before the test, and it's certainly not after the test, right? Not great. So anywho, any other questions I can answer for you?
It's just something on the homework,
Okay.
I think it was number 2 where the patient had penicillin
Mm-hmm.
but then it's like they're describing selectivity, which is cephalosporin.
Mm-hmm.
Isn't it like contraindicated if it's completely anaphylactic and just a rash?
So what do we say about that?
Not usually, it's less than 1%.
Yeah, so even if you have a patient with a true type 1 allergy to penicillin, it is very unlikely they're going to have a cross-reactivity with a cephalosporin. Especially a third generation cephalosporin is very unlikely.
Yeah, anaphylaxis really is universal.
Yeah, so that's one of the true type 1 allergies, that's anaphylaxis, right? That's kind of the extreme of it.
Less than 1%.
Yeah, so if they have that reaction and then they get a cephalosporin, it's less than 1% they're going to have that reactivity there, right? So that is reasonable to do. We've done that in several times. And most of the time patients don't have that kind of allergy. Most of the time they get diarrhea or something and then it gets listed as an allergy. So again, you can always do a test dose in the clinic, in the ER, and see how they respond to it there and then send them on their way if they have a good reaction to it. Anything else? Okay, so let's continue on with our talk in terms of our glaucoma meds. So we're still talking about ophthalmology meds. Again, what is glaucoma? Yeah, it's intraocular hypertension, right? And so what we're going to be focusing on here is obviously we want to prevent sort of progressive these retinopathies that develop because that pressure is eventually going to lead to nerve damage, which is going to eventually lead to blindness, right? And so we're going to see that there's two main types: is open versus closed angle. Closed angle is typically more of like a surgical sort of thing. That's like an immediate emergency kind of issue that needs to be taken care of. The open angle is going to be more of a chronic problem that you're going to see is more medically managed over the long term, right? And so we're going to have two different things that are really going to be focusing on here in terms of mechanisms of action. It's either to decrease aqueous humor production, right? There's nothing funny about doing that. This is how I know everyone was actually paying attention because that was a hilarious joke. But the other thing is that we can also increase the output of the fluid from that trabecular meshwork, right? So either decrease fluid production or actually increase the amount of fluid output, okay? Both of those things are going to reduce the intraocular pressure for those patients. Normally it's like 10 to 21 or so, but typically when you get those higher pressures over time, you'll find that visual field loss that will occur here. As I mentioned with the open angle glaucoma, that's what we're mainly going to be focusing on is in terms of it causing that progressive damages over the course of, say, years potentially, versus the angle closure glaucoma, that's really more of an acute issue. There's usually a lot of pain associated with that, more of like a surgical sort of emergency that needs to be dealt with. And if you're kind of looking at the two here to compare, here. You see the open angle, there's still some flow happening here, but it's going to be impeded somewhat, versus with the closed angle, there's just no flow happening at all. And that's where they get that really big pressure build up, and that's where they get a lot of that pain associated with that. So again, our goal here is to prevent kind of progressive damage. Now, if damage has already occurred, is there anything we can do to reverse that? Not really, right? So the biggest thing is to try to stave off and prevent any sort of progression of disease if possible. And so it's a lot of monitoring, especially if you have patients who have like a high-risk family history and things like that you want to be looking for. And so the drugs we have here are going to be broken down to a couple categories, and we're going to focus on them as either increasing aqueous outflow or decreasing aqueous production, okay? And sometimes you're going to have to use dual mechanisms here in order to get the pressure down correctly, right? So we're going to look at a couple different ways we can mix and match these. So the agents that are going to be good for increasing outflow are going to be the prostaglandins. Now, where have we talked about prostaglandins before? Like NSAIDs affecting prostaglandins, talk about steroids affecting prostaglandins, good. So we're going to look at these as being synthetic analogs of those prostaglandins, see how they work. We're going to look at alpha-adrenergic agonist. How do you think those work? Yeah, so we'll actually see that how they can work. Actually, this is going to be a little different. There's actually kind of a dual mechanism there, but you're absolutely right. Alpha-1 usually causes vasoconstriction. You're absolutely right there. But we're going to see that actually is going to work a little differently in terms of the eye. And we'll also see cholinergic agonists. And then to decrease aqueous production, we're going to see that also our alpha-adrenergics are here. They actually kind of pull double duty a little bit. And then you have your beta blockers and carbonic anhydrase inhibitors. So we'll get into the specifics of these as we go forward. So prostaglandins, basically they look a lot like this product called PGF2, and so they're going to bind to some of the prostaglandin receptors there, and they will actually increase the outflow. The full mechanism isn't really known, but maybe has something to do with altering that ciliary muscle contraction, or perhaps kind of affecting the trabecular meshwork and trying to affect that. The agents we have here, you can identify them when they end with prost, P-R-O-S-T, for prostaglandin. So that includes latanoprost, travoprost, bimatoprost, and then tafloprost. We've mentioned bimatoprost before in terms of it being used for another purpose, and we'll talk about that in a moment. The big issues you're going to see with this is you can see some conjunctival hyperemia, some irritation, and we mentioned the change in eyelash length. Now, is that a good thing or a bad thing? Some people think it's a good thing, right? So that's why you have latisse being used. Again, that's an adverse effect, quote unquote, that was now being used for new therapeutic purpose there, right? The other big thing though is changing the iris color, right? So you can end up seeing it turn what color? Yeah, it tends to turn brown, so it tends to darken up there. And again, if you kind of catch it early on and stop the med, there may be some reversibility, but sometimes that can be a permanent change there. And so you can see a picture here of a person who was taking a prostaglandin, how that darkened up the eye. It usually was green beforehand, and then it got pretty dark there. So pretty significant color changes. Now again, some patients may not care about that if their eyes are already brown. Some patients may care very much about that, and so that's a conversation to have. But generally, these are very effective for what they do, which is why a lot of times they're first line. Yes, sir.
Is that eyelash length a permanent change?
I do not believe it is. I think it'll go back down if you stop using the product there. Yeah. So anyway, so again, this is also nice because it only requires once daily dosing. The medication does stick around for a period of time, and so you do see some continued effects, which is nice.
The iris color is for all the prostaglandins,
Yeah, any of the prostaglandins will do that. They'll cause that browning of the iris.
but the eyelash length is only on that.
That's the only one that is marketed for that. For whatever reason, they picked that one to try it out. Maybe Bavanaprost is the only one they picked out to do the eyelash lengthening, right? And so again, that may be a little less likely if you're using it in that formulation, because in those cases there, I believe you're applying it directly to the eyelashes themselves, and so that way there's less contact with the iris, but you could still see that as a risk, right? So that's something to certainly kind of think about. Anyway, up next we have our beta blocking agents here. So as you might imagine, what do they do? Block beta receptors, absolutely right. And we have beta 1, we have beta 2 receptors. Beta 1 is primarily found where? In the heart, right? You got one heart, beta 1, and beta 2 is found primarily where? In the lungs. You got 2 lungs, right? So this is important because this will illustrate some of the side effects you can see with systemic beta blocker use, and we'll talk much more about these when we get to cardiology. But basically what they're doing here in the eye is by decreasing the production of cyclic AMP, which is a secondary messenger, they find that you'll have less aqueous humor production. And so again, when you saw the prostaglandins, they cause increased outflow. Here the beta blockers cause less humor production, right? And so here we're going to find a couple of agents. For instance, we have a beta 1 selective agent here called betaxolol. When I say beta 1 selective, what do you think that means? Primarily blocks just the beta 1 receptor. It's going to spare the beta 2 receptors. We'll talk about why that's important in a few moments here. Some other non-selective agents include things like cardiolol, timolol, and levobunolol. And how can you tell if it's a beta blocker by the name alone? OLOL is always going to be on the end of the name there, right? So that's an easy way to identify those beta blockers. So the non-selective tend to be a little bit more efficacious in the eye, but you tend to see a little bit more side effects. And remember, why do we see systemic side effects from these ocular meds? The nasolacrimal drainage, which is really why it's important to have good technique when they're applying it. Make sure they close up the nasolacrimal drainage for a few minutes after the medication's applied. However, you can see patients, if they get systemic concentrations of these drugs, some of the things you would expect to see. So if I block the beta 1 receptors in the heart, what do you think what does that do to heart rate? Should decrease it, right? What do you think it does to the contractility of the heart? Should decrease it, right? So it's a negative inotrope, which is the force of contraction. It's a negative chronotrope, meaning it's a decrease in the speed of the heart rate, right? And so can be a problem, right? If you have a patient with CHF and they have poor LV function anyway, this could lead to an exacerbation, right? If you have a patient, what if, say, for instance, I'm blocking beta 2 receptors on the lungs? What could that do? Not necessarily slow the breathing, but if you think about what the actions of a beta 2 receptor are, typically they cause smooth muscle relaxation. So normally if I'm activating beta 2 receptors, say epinephrine is activating beta 2, it will cause smooth muscle relaxation. What does that do to your ability to exchange air? It improves it, right? Because again, the airways are more open up. Well, if I block that, what could happen? They could then constrict, right? So if you have patients who have like reactive airway disease, that they have asthma, COPD, or they have some of that component to it, you can find that they may have either, it can induce an asthma exacerbation, or potentially, anyone know how you treat an asthma exacerbation? You have a beta 2 agonist, right? So if those receptors are all blocked up in the medication, then potentially that medication is not going to work so well. The albuterol is not going to work so well. Okay, we'll talk more about that in pulmonology, but that is a concern. And so by using a beta 1 selective agent, that gets around some of those problems there, right? So that way you only affect the beta 1 receptors primarily, but you spare those beta 2 receptors. That may be a little bit safer for a patient with a history of asthma, right? Make sense?
So there's no beta 2 ophthalmic agent?
Like a beta 2 selective? Yeah, not that I'm aware of. Yep. And then you're going to see that with all beta blockers, they either tend to be non-selective or they are beta 1 selective for the most part, right? I don't know if there's any therapeutic benefit to using just like a beta 2 blocker as far as I know. So anyway, so again, these are going to be fairly well received. However, in your older patients with some concomitant cardiovascular disease, this may not be a good option for them. But typically, prostaglandins are generally first line, but if they have a reason not to take a prostaglandin, a beta blocker is a good backup to that. So that's another thing to consider. Again, you can kind of review this. We talked about this already. Keep in mind when I say something is selective, remember that's all relative to the dose you're administering. If I give a high enough dose, there can be bleed over effect. You can still affect both types of receptors. And that's going to be something we see kind of throughout the course here, especially when we talk about like COX-1 versus COX-2 inhibitors, things like that. You're going to find that selectivity is all quite relative. Okay, the more I drive up the dose, the less selectivity you end up having. Okay. Then next we have our alpha-adrenergic agonists, and so these are going to be mainly working through alpha-2 agonism, right? So activating alpha-2 receptors instead of the alpha-1 we typically think about here. And so there's kind of two actions we're going to see, which is why it kind of has a dual mechanism. It has the presynaptic actions. So by activating alpha-2 receptors on the presynaptic side of things, you're going to cause decreased release of catecholamines. When I say catecholamines, anyone know what that means? Dopamine, epinephrine, and norepinephrine. Norepinephrine is probably the biggest one we're thinking about in terms of this and for our sympathetic nervous system sort of activity here. But by decreasing that catecholamine release, it kind of has the same activity as what you would see a little bit with the beta blockers to a tiny degree. So less catecholamines being released, less of those beta receptors actually end up getting activated. You also see postsynaptically, by activating alpha-2 receptors, you can also decrease aqueous humor production. So you're decreasing production, you're also increasing outflow through these two mechanisms. So that's kind of what you need to know. This is an alpha agonist, and it's doing both decreasing the production of aqueous humor and increasing outflow. We have two medications here. We have aproclonidine and then bromonidine. You will find that based on their formulations, you can see potentially some CNS side effects, but they're designed such that they don't really like to cross the blood-brain barrier all that easily. So things like aproclonidine here, it's highly ionized at physiologic pH. So what does that do to its ability to cross membranes? Something's ionized. It's easier or tougher? It's tougher, right? Ionized means it has a charge on it. So it means it just bounces off those membranes, right? So that's one of those things where you see that helps to decrease some of those systemic side effects. Because I'll tell you, when we get to talking about hypertension medications, we have drugs that do the same thing up in the brain, and what it can cause is a lot of sedation along with that, because it's decreasing catecholamine release, just like you guys are having a lot of decreased catecholamine release, because I'm boring you all to death, but you see overall decreased level of arousal and as you can see, sedation. That's also a problem, though, because if little kids get into this, you can actually see some CNS effects from this. You can see apnea, you can see CNS depression. So those are things we worry about, which is why we don't use it in kids less than 2 typically. But as we mentioned, these can be very useful. This is usually going to be an add-on agent. So you either start with a prostaglandin or a beta blocker, and then you can add this on potentially if you're not able to get the pressure down to where you want it to be. And then we have our carbonic anhydrase inhibitors. So these are mainly working to inhibit the enzyme, carbonic anhydrase. Anyone know what that enzyme normally does? Basically what it does, and you'll see this come up several times over, we'll see this come up in the diuretics section a little bit later on, but basically what it does, it prevents the conversion of CO2 and water and turning that into, anyone know? Bicarbonate, okay? Why do we care about bicarbonate? It's our major buffer in the system, right? So it's really important that we can be able to convert bicarbonate back to CO2 as well, because then what do we do with that CO2? Breathe it out, right? That's carbon dioxide, we can just breathe it right out. So it's in a very important enzyme system. We can actually affect things like the serum pH by affecting this enzyme here. We can affect things like diuresis. We can cause all kinds of effects with this class of medications. But when used in the eye specifically, by blocking the transport of bicarbonate across membranes, you're going to find that you have less ability to actually produce this aqueous humor here. So dorzolamide and brinzolamide are 2 drugs that fall into this category here. And however, there are some more side effects with it, some more bothersome than anything else. You do get a lot of that bitter taste and kind of burning and irritation. So again, useful as an add-on. And usually you're going to find this in combination as like a combo product with, say, like a prostaglandin in one of these, or say an alpha agonist in one of these mixed together there. And by combining agents, what does that do for us?
Increases compliance.
Exactly, it helps with compliance for the most part, right? Okay, now we have a couple of cholinergic agonists. I apologize for the picture covering up some of the words there. You can just resize that. Cholinergic agonists, what do you think these are going to do? Going to activate cholinergic receptors, right? Primarily, we're going to focus, and we have cholinergic receptors. What are the 2 main types we have? So the acetylcholine receptors, but there's two primary types. Kind of dig back to that like A&P class maybe you had, or maybe some of that biology class. So there's nicotinic receptors, and there's muscarinic receptors, right? What activates nicotinic receptors? Nicotine, right? Why do we care about nicotinic receptor? What does that do for our bodies? We couldn't move your muscles if you didn't have nicotinic receptors, so it's really important for skeletal muscle function. The muscarinic on the other side, though, why do we care about those? It's really important for the parasympathetic nervous system, right? The parasympathetic nervous system is mainly functioning through a lot of these muscarinic receptors here. So acetylcholine comes and binds the muscarinic receptor, and you're going to see some of these changes that occur here, okay? Anyway, so some of the things, some of the agents in this category include acetylcholine, right? We actually use this in some of our ophthalmology surgeries that we do over at Nemours. I have one doc who will frequently order these for her surgeries. But carbachol, pilocarpine. Now, these are good because by actually activating those muscarinic receptors, you end up seeing this pupillary constriction. What is that? What's another term for that? Meiosis, right? So you typically see anticholinergics cause mydriasis. This is causing meiosis because it's an agonist of the cholinergic receptors. But basically, by causing the ciliary muscle contraction, it helps to facilitate the outflow of the aqueous humor. Okay. Now, if you imagine if your eyes were kind of in a fixed miotic state, what do you think it does for your vision? Not great. There's going to be a lot of blurry vision. You're going to have a kind of a hard time accommodating. So because of that, this is not great in most patients. This is going to be sort of a backup medication, sort of a third line kind of drug because of the vision problems that are going to be seen with this. However, if your patient's already pretty progressive and you're trying to just prevent any further vision loss, then this may be an okay thing to think about. Usually, though, the younger patients is not going to be a good agent for them. Okay. And I mentioned there's combination products you can mix together, so bromonidine and timolol, so that would be an example of an alpha agonist plus what? A beta blocker, very good. Brinzolamide, which would be carbonic anhydrase inhibitor plus an alpha agonist. Again, using two different mechanisms to get synergy there rather than just using one or two of the same class, right? That wouldn't really make a whole lot of sense for our cases there. Again, fewer drops administered, better compliance for your patients. Now again, who do you need to treat for glaucoma? This is going to be patients maybe without risk factors. You kind of watch until you start to see some of those glaucomatous sort of changes occur there. But if they do have risk factors, maybe family history, then you go ahead and treat those patients. As I mentioned, either start with a prostaglandin or a beta blocker, and then you can try just therapy in one eye just to see if there's any side effects, and then go from there. In general, you're shooting for about a 20 to 30% drop in the IOP in order to get to kind of your goal. Okay. Any questions on glaucoma meds? So if I had a question that said, okay, you have a patient you're starting on therapy for glaucoma, and they have baby blue eyes, and you know they have a history. Let's just say they go with that. What do you think would be a good agent to start with? Probably a beta blocker, right? Because again, you may not want to change their iris color, right? What if you have a patient comes in and they have a history of asthma? Either a beta-1 selective agent, right, or prostaglandin would be totally appropriate there, right? Or if I say a patient's already coming in and they're on a beta blocker, what would be a good add-on agent, right? And so I may list a beta blocker and say, no, that's not right. I may list something else would be, inappropriate. But those are the kind of the questions I want to think about here. Is what are good starting agents? If a patient has a contraindication or something, what's a backup agent to use there? And then if you need to add on something, what's going to be a good option for those patients, okay? So kind of knowing the mechanisms is going to help you to be able to see where the synergy is going to come from, okay? Okay, so up next we have our ocular anesthetics. Yes, ma'am.
There's one part you just had up that had a brown on it. It looked like there's a little bit of interaction with the pupil itself.
This one?
Yeah.
What about it?
I mean, the edge of the pupil is turning white. Or is that just a funny picture?
I don't know if it's a funny picture. Maybe, I don't know. I'm not an ophthalmologist. I couldn't say. As it turns out, I'm not very good at eye exams. I don't really give them many exams. Well, the pharm exams I took, I was okay at. That's how I got here. But yeah, physical diagnosis is definitely not my gig, which is why I typically give you the diagnosis on the test, because that's what I'm kind of focusing on, right? Or the medical treatment, right? So it's a good question. Maybe you can ask someone else that might know. Dr. Levine always knows everything. That's what I figured out from my time working with her at Nemours. I was like, why the heck are you doing this? She was like, because of this paper that was done back in this time, and I was just like, oh, okay, let's do that. Okay, so any questions on that? Nothing? Okay. So talking about ocular anesthetics, why might you use an ocular anesthetic? For surgery, absolutely. We definitely use a lot of these for surgery. What does an anesthetic do? It numbs it, right? So it decreases sensation. Anyone know how that happens? What does it do? So when you have an action potential, right? Action potential is what carries nerve signals up into the CNS where you actually feel that sensation, right? So what's a really important ion to cause that propagation of action potential to occur? Sodium's really important. Sodium helps with that propagation. Sodium influx usually is what triggers off that action potential. So if I block sodium influx, that blocks the action potential from developing and sending that signal, right? So we get that sensation. So when I give lidocaine for a laceration, if I give tetracaine in the eye, these are all doing the same thing. If I were to give cocaine to a patient, anyone know why drug dealers rub cocaine on their gums to test the drug? Because if it goes numb, then you know it's cocaine because it's an anesthetic, right? It's the first anesthetic we discovered. Well, interesting fact. Don't rub cocaine on your gums. I would not recommend it. But cocaine's, I mean, that's a medicinal product, right? We have that for use for like ENT surgeries and things like that. Anywho, so they cause anesthesia through that by blocking those signals. That's why it goes numb, is because those signals, even though they may be painful, never actually get transmitted up into the CNS. So we have two agents here, tetracaine and proparacaine. Very frequently we do this either for surgery, we do this in cases of if we have like a foreign body we need to remove, we're doing tonometry, anything like that where you want to numb up the eye and prevent the patient from like really being able to feel anything or have a reaction. This is where it's going to be very beneficial here. Very few adverse side effects. There may be some hypersensitivity potentially, maybe a little burning sensation, but that should abate with time. And it's important to note that the eyes will be numb for roughly 10 to 20 minutes or so, and they don't have that blink reflex. You don't really detect that the eye's getting dried out, and so they don't blink, okay? So this is really important. So never, ever, ever write a prescription for these for outpatient use. They would know why. Because like my eye hurts, just let me, that stuff felt really great in the ER. Why can't I just take the bottle with me? Why? Because they're going to keep using it, and then they're not going to be blinking like they should be, and then you can develop corneal abrasions, and then the eye gets worse, okay? So really make sure to avoid that. Actually, there's something, just to, again, go off on a little tangent here. You know, crack cocaine. Anyone know how crack cocaine is used? Like, do you inject it? Do you snort it? Do you smoke it? Crack cocaine specifically, you smoke, right? So the free-base form of cocaine, or crack cocaine that is formed, you can smoke that, okay? And what's interesting is you have patients who would come in and they would have these like corneal abrasions, these conjunctivitis. You're like, what's up with these guys' eyes? What do you think was happening there? The vapor was coming off and it hitting the eyes, and guess what happened? Numbed up the eyes. They don't have that blink reflex, and guess what? Boom. Now you have that ocular injury. They call it crack eye. If you ever hear that, that's what this basically is referring to. And it can, huh? Probably roughly similar. Again, it just depends on how much you're actually getting, the vapors actually affecting. This is more of a chronic issue that would develop for them over time, right? And again, it could be a totally incidental finding because, again, your patients may not be coming in for that. They could be coming in because they have chest pain associated with cocaine use, or they got arrested and they're coming in and they're saying, oh, my eye hurts, right? So again, it could be another reason to check that out, and that's a reason why you could see that develop there. So little things you might see. I don't know what the specific drug utilization patterns are here, but if you go to like downtown Jacksonville on 8th Street, all you see all day long is just crack chest pain all day long. So that's something we definitely saw a lot of. But again, if you go out into more of the rural areas, what do you see a lot of? A lot more amphetamine utilization there, right? So obviously opioids are super common as well. But again, the crack eye is kind of one of those unique things of the fact that the dosage form that they're using, the inhaled form, and the fact that it's an anesthetic itself. So it's kind of interesting point. Anyway, so frequently the anesthetics will get used along with other agents as well for diagnostic procedures. So for instance, we have cycloplegic agents. Anyone know what cycloplegia means? Basically, it's preventing the eye from constricting down, the pupil specifically, right? So you're actually causing mydriasis with these agents here, okay? So we do this a lot so that way we can get a better view for our fundoscopic exams. We do this a lot in cases, so we have like premature neonates that are born, we look for retinal hemorrhages and things like that. So frequently we'll give tetracaine plus a cycloplegic agent so that way the ophthalmologist can come through on their rounds and do eye exams for all those little babies. And so there's a couple of different ways we can do this. First off is going to be the antimuscarinics. And this makes sense because we talked about the muscarinics before, and what do they cause? Meiosis, right? So an antimuscarinic should do what? Mydriasis, absolutely, right? So again, when you get your eyes dilated at the optometrist, this is possibly one of the agents you're receiving is an antimuscarinic, right? It's things like atropine, things like cyclopentolate or tropicamide. Now, as you might imagine, what are some of the side effects seen with that? Can't see, right? Because why is that? yeah, your eyes are dilated, you're photosensitive, and the lens can't accommodate right. You can't focus on things whether they're close or far away, right?
This one actually lasts a little bit, right?
So that's the thing. So we'll find that the duration of action actually lasts longer for the antimuscarinics than it will for the other class we'll see in the next slide here. So this tends to last a little bit longer. That's why, like, if you had to have someone come pick you up from the optometrist because you had your eyes dilated, it's because this lasts longer than what you're going to see the other agents. We have other agents that are sympathomimetics. When I say sympathomimetics, anyone know what that means? So it's mimicking the sympathetic nervous system. So these are agents that will cause similar effects to norepinephrine and epinephrine. So by binding to this adrenergic agonist, and if you're in a fight or flight response, what happens to your pupils? They dilate as well because you want to get all that light in so you can see that aggressor coming at you and run away if you need to, or whatever the case may be. So your pupils dilate, and so these drugs will do the same thing by acting on those alpha receptors. They'll dilate the eye, leads to that mydriasis, and typically the eye remains a little bit more reactive to light than the antimuscarinics do, so this is not going to be the same degree of cycloplegia that you'd see with an antimuscarinic, and the duration of action is usually a little shorter. And phenylephrine is probably the most common one that we'd see being used here. And I've seen some ophthalmologists use both an anticholinergic plus a sympathomimetic. Sometimes they might use one or the other. We tended to use a lot of phenylephrine in the ER because frequently we just need to do a quick exam, look for corneal abrasions or something, do a fluorescein stain, and then they're done and we can send them on their way, right? Versus the ophthalmologist may need it for longer periods of time, okay? So speaking of fluorescein, what is fluorescein? Anyone know? Yeah, it's a dye basically we can place in the eye. Usually have strips that you basically can place into the cul-de-sac, and that will then allow the patient to blink, and then that will kind of wash the dye over the eye itself here. And so we can use this along with the Woods lamp to look for any kind of corneal abrasions, corneal ulcerations, things like that, and that can help us in making our diagnosis of why a patient's coming in with eye discomfort or something like that. Typically pretty well received. I will tell you though, kind of a funny thing with using a lot of computerized methods of order entry nowadays. I have this one doc who every single time he wanted to order fluorescein, he could never find it in the system. Why do you think he couldn't find it? Because every time he looked for it, he typed in FLO, enter it, right? Can't find it, right? So unfortunately, some of our systems aren't quite as good as Google to figure out, oh, you actually meant this. The system's just like, no, there's nothing that has FLO in it. So I had to go, it's FLUO, and he goes, okay, here it is, and clicks on it. I always had to remind him of that. But again, sometimes we can't find things. That's the reason why. I had one nurse who was trying to get a prescription pad out of the Pyxis machine, the thing that usually dispenses medications. We kept some pads there, and she went to go pull it out, and she couldn't find it. She's like, I can't. Every time I keep searching for this, I can't find it. What do you think it was? She was searching for a prescription instead of a prescription. Again, spelling does count in some of these cases there. She was so mad. She was like, where's this thing at? This machine doesn't work. And I said, try PRE. And she's like, oh, okay, thank you. Bye. They hang up usually pretty quick after that for whatever reason. So anyway, so that's it for the ophthalmology section. Any questions on that? Checking to see if I got any notification.
We just sent one.
I
It's
d-
not available to download yet.
Not yet?
Within 15 minutes.
15 minutes, fantastic. So you guys have any other questions, perhaps I can answer about the exam before I let you go on a break, and then we'll come back and then take it. Is that reasonable?
Yes.
Any questions at all? Anything you think of?
Are we being lectured after the exam?
Do you want to be lectured after the exam? I can come back and I can do like a couple more hours if you want, or get ahead of things. No, I will not be lecturing after the exam. We'll consider this it for today. Anything else I can answer for you? Any questions at all? So comfortable and confident? No? That's okay. So let's go ahead and do, let's take a break. I'm going to see if Dr. Payne's here, see if he wants to talk to you guys, and we'll go from there. Okay, so just hang tight. Yep.